And my topic for today is the value of ultrasound for the evaluation of chronic liver diseases. In normality, usually liver it's a structure, normal structure, and we can see very well hepatic and portal vein, and you see this in normal presentation. But what we try to find in pathological condition, and for this we look for steatosis and the sign of advanced fibrosis. For steatosis, we have bright liver with posterior attenuation, and for advanced fibrosis, we look for homogeneous liver, for the surface of the liver, sign of portal hypertension, side of the caudate lobe, we look for the side of the spleen, and we look for ascites. Looking for steatosis and quantification of the severity of steatosis, the sign of steatosis is bright liver with posterior attenuation, and these are in different degree, and we have modified the hepatorenal index comparison between the liver and the right kidney. And in this condition, if we work with ultrasound, standard ultrasound, the accuracy for steatosis detection and the quantification can reach 80–85%. These are two images of this condition. On the right, you can see a bright liver, and this is a posterior attenuation that makes difficult to find the diaphragm. And we have here a second situation in intercostal section, bright liver, and the ratio is here like some. And there are some papers, some research in this field that try to find the value of this bright liver echo pattern. And this is first is the study of Palmentieri, and was a comparison between liver biopsy and echographic aspect of the liver. And in 235 patients, found in the bright liver echo pattern was found in 67% of the patients with any degree of steatosis, and in quite of 90% of the patients with severe steatosis. And then in this condition, for patients with severe steatosis, the sensitive specificity of ultrasound is more than 90% for liver steatosis. Other study, Mathisen, where they compare ultrasound with liver histology in 165 patients, and they found that increased echogenicity of the liver was found in 86% of patients with at least moderate steatosis. And you can see here that the specificity, predictive and negative value is somewhere between 0.82 and 0.90. Then it's quite good for our practice. This is a meta-analysis that was published some years ago in more than 4,000 subjects, where they found the sensitive ultrasound for moderate and severe steatosis was 84, and the specific was 93 in comparison with liver biopsy. Then are very good results from this meta-analysis that permit us to use this method in practice for quantification, the subjective quantification of liver steatosis. We can use the control assisted diagnosis, or the new name of artificial intelligence, for evaluation of steatosis. And in two publications of our group, we found that this computer assisted diagnosis for a classification, correct classification of degree of steatosis was 82%. And more papers are now showing the value of artificial intelligence for this purpose of quantification of steatosis using ultrasound waves. Then we have in the last years something new, and this is ultrasound-based steatosis quantification. Because in the last model of ultrasound machine, we have a module for numeric quantification of steatosis, and you can see in image different system of quantification. First is so-called UGAP, second is ATT, and third is ATI. And these make possible quantification, numeric quantification of steatosis. And you can see for this system from General Electric, then the accuracy for mild, moderate, and severe steatosis is very high, more than 0.90 for quantification of steatosis. Then it's a good hope for ultrasound in this field. And this quantification is a numeric one, and it's very objective, and we enjoy to have it in our ultrasound machine. But we have some limits of ultrasound for liver steatosis. We are not able to make differentiation between steatosis and steatohepatitis, and between muffled and mesh. And the problem is this is valid not only for ultrasound, but this differentiation is not possible for the of MRI. Then what we can say this is a steatotic liver, but without being able to say that it's inflammation or not, at least in this moment. And then we go to fibrosis and how we can use ultrasound for fibrosis assessment. We can have classic ultrasound evaluation of the liver, looking to the structure, to the surface, splenomegaly, or we can have modern method for liver citizen assessment, and here we have ultrasound-based elastography. I will start with some very typical image. This is the longitudinal section where we can see the caudate lobe that is very large, more than 35 millimeters, and the very typical sign of advanced fibrosis or cirrhosis. We have here splenomegaly in these two situations. Normal spleen is still 12-13 centimeters more than this. Means splenomegaly and ultrasound is very good for this measurement. We have the caudate lobe enlargement here. This is the caudate lobe enlarged. We have a heterogeneous structure of the liver. It's not homogeneous now that it's a liver structure, but it's heterogeneously, like of same sign of cirrhosis. This is a heterogeneous liver with perihepatic ascites, and here it's a large wall of the gallbladder, or sign of liver cirrhosis. Perihepatic ascites and irregular surface of the liver. And now something from the literature, and is a publication made by the Italian group, where they look prospectively between ultrasound and liver biopsy for evaluation of hepatic fibrosis, and comparison was made with liver biopsy. And the ultrasound diagnosis of liver fibrosis have a very low sensitivity, 25%, but a very good specificity, and then diagnostic accuracy of 80%. Then we are not able to say then it's a chronic hepatitis, but if we are signs of cirrhosis, we are very specific and we can say it's a liver cirrhosis, and I will show in previous image. There are two papers that were published looking to advanced fibrosis or cirrhosis. This is one in chronic viral hepatitis, where they compare ultrasound with liver biopsy. They look for the surface of the liver or structure of the parenchyma, to the diameter of the blood vessel, portal vein mainly, blood flow velocity and spleen size. And using only one parameter like liver surface, the sensitivity is not very high. But if they use the 2 or 3 parameters from ultrasound, they can have a predictive, negative predictive value that is close to 0.95. Then we can exclude the advanced fibrosis. Other study looking again to the advanced fibrosis and or cirrhosis, and they compare ultrasound with liver biopsy in 225 patients with chronic viral hepatitis. And if they look to echo pattern of the hepatic parenchyma, to the liver surface, and to the gallbladder wall, all are very simple parameters, then the accuracy of ultrasound for diagnosis compensated liver cirrhosis was 80%. Some people believe that we can use Doppler ultrasound for evaluation of severity of hepatitis. And the publication from 2005 showed the Doppler derivative indexes that previously was recommended for evaluation of severity of fibrosis have a limited clinical role in non-invasive assessment of hepatic fibrosis. Then in this time we don't use these Doppler derivative indexes for this purpose. We can use maybe sometime ultrasound with contrasting ultrasound and inject the view, and then hepatic arrival time of contrast and enhancement of the in liver parenchyma can be used like a sign of advanced fibrosis. And some studies show that hepatic vein arrival time can be correlated with severity of fibrosis. What I like to say here, in this image, it's a pseudo correlation of the liver and kidney, and the arrival time, the time when the contrast arrives in the kidney very early, and then in the liver, and this comparison between kidney and the liver, the arrival time of the contrast in this can give us some information about fibrosis. It's a publication showing this using the contrast ultrasound of the liver for the assessment of fibrosis with a very good correlation in this study. Or in this so-called parametric arrival time here, this is the kidney, this is the liver, and you can see here the time when the contrast arrives. For example, in the kidney, it's earlier than in the liver. You can see somewhere after 10 seconds in the kidney and somewhere 20-25 seconds in the liver with green and this violet. Something about contrasting, about evaluation of liver fibrosis using ultrasound-based liver elastography. In this moment, these shear elastography are implemented in many ultrasound machines, modern ultrasound machines. We have two types of liver elastography. First is transient elastography that is not in ultrasound machine. And the second is shear elastography. These are very good methods because in a very short time, less than 5 minutes, we can explore and to have confident results looking to the stiffness of the liver. The results are expressed in kilopascal or meter per second, mainly the American use is the meter per second. And there are a lot of publications showing very good clinical results of this stiffness evaluation for all the system. This is so-called point shear elastography. This is we must look by ultrasound to the liver and then put a box here, push a button, and we have the results here. Or in other system, the same, the liver, the box, and we have the results expressed in meter per second or by in kilopascal. To be shear elastography, then or real time, it's a color codic and numeric one. Then we have a color that show us the stiff of the liver, then it's not fibrosis here. And we have here the value, because inside this box we put a ROI, a region of interest, and then we have a value. And here we can see the color, this time yellow somewhere here. Then it's the fibrosis, and the value is 20 kilopascal, that means it's a liver fibrosis. Then a very good method, color coded and numeric one. Then in this moment, we have in our hand on the other part, we have so-called multiparametric ultrasound. Then multiparametric ultrasound means that we can have a lot of information in the same evaluation. And it's a study that was published last year, where in 120 patients, they compared liver biopsy with multiparametric ultrasound, and they obtain information about three type of information. First is about inflammation in the liver, and our rockets are very good here. Then they look for Statosis, and again have our rock that is quite high. And they look to liver stiffness for fibrosis, and this is higher 0.88 till 0.95-fold liver cirrhosis. And if we put together all this information, we can have an ROC for diagnostic non-alcoholic steatohepatitis of 0.81. Then it's very, very good for our daily practice. Then we can use this multiparametric ultrasound for our daily practice. And then we can say that we have in our hand with this multiparametric ultrasound, so-called one-shot stop. Then with ultrasound, we can look to the structure of the liver, that is homogeneously or not inhomogeneously. We look for steatosis and we can quantify the severity of steatosis. We can look to the presence and make a quantification of the volume of ascites. We can look for the masses in the liver if they exist, and then we can use Chew's contrastinous ultrasound for characterization of this. And finally, using ultrasound-based elastography, we can make estimation of fibrosis, steatosis, and more recent of inflammation. Then, like conclusion of my presentation, we have some simple things. And regarding the use of classical ultrasound for the evaluation of fibrosis in the liver, this is with low sensitivity, but with an accuracy of 80 for the diagnosis of liver cirrhosis. For liver steatosis, a bit moderate, this standard ultrasound is quite good for evaluation of severity. On the other hand, we can use ultrasound for evaluation in patient liver cirrhosis, including the screening for hepatocellular carcinoma. Elastography, ultrasound-based elastography are now implemented in our new machine and we use in our daily practice. And multiparametric ultrasound is this new modality of evaluation of the patient with chronic liver disease with very good result for our daily practice. This is a very nice fold that is in our area and it's in this thing, and I recommend you to come to see this wonderful landscape in Banat County. Thank you.
Thank you very much, Johan, for your presentation. And we have some minutes. Tudor, you can use it to prepare the next lecture we can discuss. Are there some questions in the chat, please? There was one question about the importance of fibroscan elastography in NASH, and I think you gave already the answer for that. But what do you think we have not in the distribution of elastography? It's not available in every hospital or in every practice. How expensive is it to order the tool of elastography inside of a machine?
Dieter, do you know, these are last research was published last year or something like this, but the future is in the direction that all the machine, all the company have now such module for evaluation. On the other hand, now these modules are implemented not in high-tech machine, but in the middle-class machine. And in my vision, maybe in 5 years, we will have quite all the machines that appear on the market will have a module for evaluation, because now is the fashion. Like to have. We can use ultrasound for steatosis. That is quite simple. How I shown. Then you can make evaluation of steatosis by standard ultrasound. But for fibrosis, only advanced fibrosis can be evaluated or can be diagnosed by standard ultrasound. You need elastography for have staging or fibrosis from mild to severe or something like this.
Okay. What is the frequency of biopsy, of liver biopsy outside of studies? How often you do it in your department? What do you think?
You know, I told 2 years ago, then we decreased 10 times. Now we have maybe 10%, between 5 and 10% of the number of liver biopsies that we had 10 years ago. Then this 90, 95 decrease of the number of liver biopsy outside study.
Mm-hmm. Okay. In your conclusion, you also announced that it's possible to check the amount of ascites or free fluid. I think that's a little bit difficult to say how many ascites is there in the abdomen. How do you do it?
You know, usually we say mild, moderate, or severe ascites.
Okay.
For us with long experience, usually I try to transform this large amount of ascites in a number of liters, 10, 15, but it's speculative one. Probably it's more correct to say mild or minimal. Usually I say minimal ascites, mild ascites, moderate ascites, and severe ascites. Looking in all the pouches, we look in the Douglas pouch, we look perisplenic.
Okay. And when do you make a diagnostic puncture of the ascites? In which cases? Only when you have an echogenic ascites, some echoes inside of the ascites, or in which cases you make a puncture and diagnostic puncture?
The strategy is that usually all patients that come in the department to have a puncture, because the infected ascites can be without any clinical sign. Then we make puncture in case it's coming in the hospital to diagnose asymptomatic infected ascites.
Okay, thank you very much, Johan, for your presentation.
I also have a question for Professor Spora, if you allow me. Professor, how many physicians, how many internal medicine doctors do you think have access to all these features that you have presented, like the multiparametric concept? How many of them do you think have access to, for example, FibroScan in percentage?
Tudor, I'm not in favor of FibroScan. FibroScan is a machine for people that don't perform ultrasound. I don't like too much FibroScan. Okay, but I like the module inside the ultrasound machine. And it's the future. I know that not many people have. Maybe in Romania, we are a little lucky looking to many centers, because it's quite well developed this evaluation. But this is the future. We are not able to stop this future. And you know, some years ago, Point was implemented in a medium class ultrasound. Now, quantification of Statosis is implemented in a standard ultrasound. In the future, we can speak in 5-10 years, and I believe then will be very, very common, because all these tricks or all these modules, these are only in high-tech machines. But now the way is to have this module inside middle, and I'm very sure in 5 years in low, medium class of ultrasound machine. That is the future. This is the direction. Is not the present, maybe, I don't know exactly for some country, but it's the future for all of us.
Thank you.
Thank you very much. If you, to our audience, if you want to give us a question, please write in the chat or open your video camera, then we can see you. And only in this situation, if you want to give contribution to discussion, open your microphone, please. There's no other question. We have 91 participants now. That's great. And the next part is Tudor Moga will give us a presentation in our journal club. And yeah, we will see.
Thank you. Yeah, thank you. I'm quite happy to be part of this team. And I will present you the Ultrasound Journal Club. And I have prepared 2 papers two simple papers because the majority of the participants are students, so it's better to establish the simple things and what can we do with a simple basic ultrasound device. Actually, the question that I have addressed to Professor Spora was kind of a door opening for my next presentation. And my next presentation, I will present you a paper that was published in Medical Ultrasonography a few years ago about the assessment of liver steatosis using standard ultrasound. So, of course, there are a lot of new options, features that are now embedded into the new ultrasound machines, but the majority of the physicians probably have a standard B-mode ultrasound, and it's important to know what performance they can obtain with this standard ultrasound device. So this is why I've chosen this paper. We know that hepatic steatosis summarizes a wide spectrum of conditions that are characterized by triglyceride accumulation within the cytoplasm of hepatocytes. So the fat accumulation inside the fat, meaning hepatic steatosis. It's quite frequent in patients who drink alcohol, but it's also in those who are not consumers. And you know, you might already have heard about the non-alcoholic fatty liver disease entity. So it's quite a frequent disease. Hepatic steatosis can progress to steatohepatitis, which is an active form of the disease. It can progress with fibrosis, cirrhosis, and even complicate with hepatocellular carcinoma. On the other hand, steatosis is a well-recognized cofactor for the accelerating of all the chronic liver disease. It's very commonly in daily practice, and it's also very often in patients with obesity and diabetes mellitus. According to a meta-analysis made on 14,000 patients, they found out that 60% of the patients had hepatic steatosis at basic ultrasound evaluation, and more than this, in patients who had chronic liver disease, half of them had hepatic steatosis. What about the ultrasound diagnostic criteria for hepatic steatosis? Well, the ultrasound changes in hepatic steatosis only became apparent when the fat content in the liver is above 15-20%. And when we have 15-20% of fat accumulation inside the liver, then the bright liver, as Professor Spora was mentioning, appeared. The hyperechogenicity of the parenchyma. We also have other criteria like the ultrasound attenuation and the difficulty of visualization the other hepatic structures inside the parenchyma. So the bad acoustic window will appear. Like in this picture, you can see the brightness of the liver in contrast with the renal parenchyma. You can also barely depict any other structures inside the liver. But we have to have in mind that it's only a qualitative assessment of hepatic steatosis, so it's not a quantifiable measure. It can only help us in establishing if it is mild, moderate, or severe steatosis with a poor or no visualization of the intrahepatic structures and also the diaphragm and the right liver of the liver. In this picture, you can see a grade 1, grade 2 steatosis, and in the bottom pictures, you can see grade 2 severe. In the left one, you have a more severe fat accumulation in the liver. What about the performance in detecting steatosis? Well, it's considered that ultrasound has between 60 to 90% sensitivity and 88 to 95% specificity in detecting hepatic steatosis. In a meta-analysis that included almost 3,000 patients, the overall sensitivity of ultrasound in discriminating moderate to severe steatosis was almost 85% with a ROC curve of 0.93, meaning excellent results. In another meta-analysis, they evaluated the performance in detecting steatosis. And we know that there are a lot of parameters in helping us depict the liver steatosis. So they found out that the liver to kidney contrast So the liver to kidney index is the most sensitive in depicting hepatic steatosis, comparing it with the other parameters like vessels, wall brightness, or deep beam attenuation. Just pay attention that this performance is in detecting moderate to severe steatosis. In the cases of mild steatosis, the performance is a bit lower. The high sensitivity and specificity for the presence of steatosis will appear only if the fat content is more than 20% of the liver parenchyma. There are also some factors influencing the ultrasound performance in detecting steatosis, like the fibrosis, the age, and the body mass index. They were associated with the quite strong agreement between the ultrasound and histology. And also there are some studies that notify us that ultrasound in morbidly obese patients can reduce the sensitivity. So the performance of ultrasound in depicting hepatic steatosis is a little bit lower in patients that are obese. There is also an intra and inter-observer variability in what concerns the diagnosis of hepatic steatosis by standard ultrasound. So it's quite a variable method, and we have to take that in consideration. Probably with experience, also the results are more reproducible. There are also some studies talking about the Doppler examination, and they found out that, yes, indeed, in patients with moderate to severe steatosis, the blood flow is quite abnormal in almost half of the patient, comparing it with those with only 2% in normal individuals. There is also a model of steatosis, if we talk about the focal fatty infiltration, and which is a localized steatosis and focal fatty sparing, meaning an area that was not accumulating fat content, probably due to the vascularization. So you can have also these situations when performing ultrasound in daily practice, which can always be
recording in progress
with liver lesions or other hepatic structures. The diagnostic of ultrasonography in hepatic steatosis has also some limitations, like it cannot differentiate between the steatosis and steatohepatitis. So standard ultrasound, it's good only in diagnosing steatosis, but we don't have any information about the active form of steatosis, the steatohepatitis. It cannot establish with certainty the degree of fat infiltration, and it cannot differentiate between steatosis and other diffuse liver disease that I've shown you precedently. A new feature appeared that can allow us to quantitatively assess the steatosis, which is control attenuation parameter that was presented in the previous presentation, that actually estimates the ultrasound beam when go and return path from the transducer. And we have also some cutoffs for mild, moderate, and severe steatosis, meaning that we can quantitatively assess hepatic steatosis by this ultrasound-based feature. And as for the conclusions, we have to keep in mind that ultrasonography is an established tool used as screening modality with acceptable sensitivity and specificity in detecting fatty liver disease. So it's the first weapon and the first tool in evaluating and establishing this diagnosis. Nevertheless, it has also some drawbacks because it sometimes might be inaccurate and also has some problems in differentiating the fibrosis from steatosis, and also about the reproducibility of the method. We have some drawbacks. This was the first paper about hepatic steatosis evaluated by standard ultrasound. The next paper is about contrast-enhanced ultrasound for the characterization of focal liver lesion. As you all probably have heard until now, because it's not a new method anymore, it has 15, almost 20 years now, but still is not used as it should be. And it was the game changer in what concerns the liver evaluation, focal liver lesions evaluation, because it brought a lot of benefits. And as you will see, it influenced a lot the performance and the attitude towards liver lesions. So it's a German study, a multi-center German study that evaluated the contrast-enhanced ultrasound for the focal liver lesions diagnostic accuracy in clinical practice. So it's quite useful for the clinical practice. It was the landmark of the later on studies in what concerns the performance of contrast-enhanced ultrasound. And we all know that the incidental findings of liver lesions that needs to be characterized is one of the most common clinical issues because they are quite frequent, especially the benign liver lesions in general population. So not all the cases we are able to evaluate a lesion only by standard ultrasound, as we can do in maybe simple cysts or hemangiomas or maybe focal fatty changes. Some lesions need to be further on evaluated. And unfortunately, in clinical practice, there are many lesions that do not fulfill this diagnostic standard ultrasound criteria, and these lesions need to be evaluated further on. And when we say further investigation, we actually refer to computer tomography or magnetic resonance imaging, both of them with contrast medium. And we all know that they are quite sometimes costly, sometimes they have side effects, and sometimes they take too long. But with the appearance of the microbubbles, the special contrast for the ultrasound devices that uses a sulfur hexafluoride gas in a lipid shell, that means that it will be eliminated from breathing, from the body through breathing, the paradigm of focal liver lesions have definitely changed, because a lot of lesions that were previously sent to other cross-sectional imaging now can be evaluated in 2 or 3 minutes. And the aim of the study was to evaluate the diagnostic value of CUs for the differentiation of focal liver lesion in clinical practice. Was a multi-center study published from 2000. They evaluated patients from 2004 to 2006, and they included almost 1,500 patients. The majority of them had an incidental finding, so they were healthy patients performing a standard ultrasound, and they were depicted with focal liver lesions. 70% of them had underlying liver cirrhosis, and 27% of them had an extrahepatic malignancy. Each patient underwent a standard and complete examination with standard ultrasound, and they were evaluated also by contrast-enhanced ultrasound. I have to mention once again that the contrast medium used in ultrasound is not nephrotoxic, is not cardiotoxic, and later studies appeared and they say it's quite safe. In more than 10,000, 20,000 studies, we didn't have any complication regarding the procedure or the contrast medium. So it's quite a safe contrast medium. It will be evaluated by 3 vascular phases: the arterial phase, meaning the arterial blood supply of the liver, the portal venous phase, and the late phase that will appear after 20 seconds. So standard CUS evaluation will be evaluated properly following these 3 vascular phases. All the lesions were analyzed according to this enhancement pattern and were described accordingly. So in this situation where we have a focal nodular hyperplasia, you can see the spoke wheel enhancement with the central artery and so on. And each lesion was evaluated in the arterial, portal, and late phase. In this situation, we have hemangioma with a nodular centripetal filling. In this situation, we have a liver metastasis, and here we have hepatocellular carcinoma. The last 2 will present washout, which is a criteria for a malignancy in CUS evaluation. Okay, what about liver tumor characterization? All of them were assessed according to this manner, and they were a real-time assessment of contrast enhancement pattern. So when we are talking about CUS, we can have hypo-enhanced, iso-enhanced, or hyper-enhanced, meaning that the enhancement is better than the liver parenchyma, always comparing it with the enhancement pattern of liver parenchyma. Of course, also the location and the initial contrast pattern were described when performing CUS. In what regards the results, well, CUS, according to this study, was able to assess 95% of the cases, meaning that it's a feasible method. The real-time assessment of the successive vascular phases of the liver perfusion had the following contrast enhancement pattern. So in the arterial phase, 65% of the lesions were hyper-enhanced, 26 of them were iso-enhanced, meaning had the same enhancement pattern with the liver parenchyma, and almost 7% of them were hypo-enhanced, meaning that they were less enhancing than the liver parenchyma. If we talk about the portal phase, the majority of the lesion, 26% of them, they were iso-enhanced, meaning that they have the same, meaning that they were hyper-enhanced, the majority of them were iso-enhanced, meaning that they have the same intensity of contrast like liver parenchyma, and 30% of them were hypo-enhanced. In the late phase, 36 of them were iso-enhanced and 61% were hypo-enhanced. The differentiation between malignant and benign liver lesion is quite good in use in clinical practice, with a sensitivity of 95% and the specificity of 83%. So it was an excellent method for establishing the malignancy of the lesion, which is quite important, mainly in clinical practice, when you can put a diagnosis in a few minutes and you can talk later on and establish the strategy and the management of the lesion. The positive predictive value of CUS for the classification of malignant lesion was 95%, and the negative predictive value was the same, 95.9%. The performance, you have here a table with the performance of CUS for the whole lesion, and you can see it's quite good performance, 95% and 83% the specificity, and they also differentiate the lesion in lesion more than 2 centimeters and less than 2 centimeters, and the sensitivity and the specificity were quite the same, so there wasn't a big difference in what concerns the size of the lesion. I also inserted a few images in order to have a better view and a better understanding of how it works and how you can easily evaluate the enhancement pattern of the lesion. And you can see here a lesion in the standard situation, and in the arterial phase, you can see that it can easily differentiate from the rest of the parenchyma. It is hyper-enhancement, iso-enhancement in the portal phase, and in the late phase, it's still iso-enhancement. No washout, probably it's not a malignant lesion. In this situation, we have a focal nodular hyperplasia. In this picture, we have a hemangioma, which is a little bit difficult to depict in standard ultrasound, but when we add contrast medium, when we add the microbubbles, you can see how nicely it differentiates from the rest of the parenchyma with the nodular centripetal enhancement pattern. Here is the portal phase, and in the late phase, you can see that it's still a little bit hyper enhancement, so no washout, meaning that it's not a malignant lesion. In this situation, however, we have a lesion that is quite easily depicted in standard ultrasound. And if we had contrast, we add contrast to this evaluation, we can see the enhancement pattern, hyper-enhancement pattern, when comparing it with the adjacent parenchyma. And starting from the portal phase and late phase, you can easily depict here the washout phenomena, meaning that there is malignancy in this situation. And these are the reference, and I thank you for the audience. And if there are any questions, looking forward to answer or maybe comment the observations.
Thank you very much for this presentations of the two very important and interesting papers. Are there some questions? Are there some comments? And how many lesions are less for a puncture for an interventional procedure if you have so good options of contrast media ultrasound to differentiate between malignant and benign lesions? Is it necessary to make a puncture to differentiate?
Well, in a lot of situations, yeah, it's still necessary to puncture the lesion, because also the oncological treatments have evolved a lot, and recently they will give targeted treatments, so they will need to see exactly the receptors inside the tumors and so on. But in what concerns the diagnosis, I think we can easily put a quite confident diagnosis on a simple COS evaluation. So more in the management, in the treatment management, we still need the biopsy. But in what concerns the diagnostic management, I think COS is quite an important asset that we have successfully gained in the last years.
Okay, thank you very much. Are there some questions? I found questions in the chat about can they look in the recorded lectures. I think we will organize that next week you can see it, and you will find the link on the WFUMB website. We will discuss it with the people of the organization of WFUMB, and then you can look there under students webinar, and you can find all that if you want to see the papers or some other things. Some other comments? Thank you very much, Tudor, for your contribution. And you have heard already, we come to the next point. You heard already about the paper, about the focal lesions of the liver and how it's possible to differentiate. And Roxana Sirli, Professor of Gastroenterology from University Timisoara, will give us a presentation now, how to differentiate and what.
Professor Peter,
yeah.
Sorry, there are two questions in the chat that just appeared, if you allow me to answer them.
Okay.
So one question is COS expensive in Europe? Well, I don't know exactly how much a vial will cost, but around 80
euros. It is around 30 euros, but you can use a vial for more than one patient, because for more than one lesion. For contrast enhanced ultrasound, you need one examination for each lesion, so one injection for each lesion. But from a vial, you can perform 2 or 3 injections depending on the performance of the ultrasound machine. Because the more performant is the ultrasound machine, the lesser the quantity of ultrasound contrast agent that you need to use. But you need one injection per one lesion. Another question is, what type of contrast do you use for ultrasound?
Yeah, well, we use at least in Romania, we use Sonoview. It's from Braco. It's I think a contrast agent that is mainly used in Europe, and it has quite good results, and we are happy with it. But I think there is also other types like maybe Sonazoid or other contrast medium that are available only in United States, or if I'm not mistaken,
in Asia.
And in Asia.
And it has the advantage that it accumulates in the Kupffer cells, and you can explore the lesion. It's hepatospecific, and you can explore the lesion even in very late phase. It is not available in Europe, as I know.
In Norway, it's available, but yeah, there. Well, the thing is that I didn't mention this, but the contrast medium will disappear in a matter of 4 to 5 minutes. So this is why Professor Shiri was saying about the Sonazoid and the advantage of persisting more than 8 minutes, I think, in the liver, because it will allow us to better analyze the image.
Okay, There's another question from Walter, Miss or Mr. Walter. There's usually a challenge scanning fatty livers in obese patients, but clinicians still refer these patients for HCC surveillance. Why don't they use CT scan instead? Who wants to give an answer?
Well,
okay, I'll do it. Well, indeed, the fatty liver is much more difficult to examine. But as I should underline that in order to perform contrast-enhanced ultrasound, you should see the lesion in B-scan mode. If you don't see it in B-scan mode, you cannot do a proper contrast ultrasound examination. Why don't you do a CT in all the patients? It is expensive, it is irradiating. Of course, that in cases when you are not certain that you have seen the entire liver, or when the liver is highly, has a highly irregular structure, and you are not sure that you see or not a lesion, you should refer the patient to CT or to MRI. But CT scan is irradiating, is expensive. MRI is not irradiating, but it is much more expensive. And since we are talking about costs, a question was if the contrast agent is covered by the insurance. In Romania, yes.
Roxana, I like to underline something. This screening by ultrasound is made every 6 months. Then means during the life of a patient, liver cirrhosis can have 20, 30, 40 examination. If we give CT scan to this patient every 6 months, it will be a big mistake by the quantity of radiation. Then this screening is made every 6 months.
I think a short comment. I think sometimes also in obese patients, lesions are better visible with contrast media ultrasound, and they are not visible without in B mode, but you can see it in contrast media ultrasound. In Germany, the other thing is in Germany, CT and MRI are no screening methods. They are too expensive. If you want to use and you want to an examination in a risk group, then you have to use a screening method what is cheap and what is available everywhere. I think that's why we don't use it. Okay.
There is one more question that I think it is important, and maybe Professor Spora, you can answer. How do you compare the sensitivity and specificity of contrast-enhanced ultrasound with triphasic CT in the diagnosis of hepatocellular carcinoma? It's on the chat. You should unmute your microphone, Professor Spora.
Okay. Which is the question, Roxana?
How to compare the sensitivity and specificity of contrast-enhanced ultrasound with CT in the diagnosis of hepatocellular carcinoma?
Okay. Then usually when you have a lesion, for doctors that perform contrast-enhanced ultrasound, we start by performing the cheapest method, a very quick, a point-of-care method, that is contrast-enhanced ultrasound. The sensitivity of contrast-enhanced ultrasound in paper for ACC is somewhere between 70 and 80, but with quite a high specificity, then it's more than 90%. If the diagnostic by contrast-enhanced ultrasound is clear, we stop our diagnostic procedure. If it is not clear, usually we go directly to MRI, or we can go to CT scan, contrast-enhanced CT scan, or we can go to MRI with contrast, or we can have specific contrast for this. But for this, for example, for MRI, it's a waiting time. This waiting time in practice can be between 3 days and 3 weeks or something like this. But contrast-enhanced ultrasound, we can perform after 5 minutes. We put a branula and we make the examination. And saying maybe in 3 cases in 4, we have the correct diagnosis of ACC.
We come to the last questions from Yuhong, our colleague. Is it paid, the contrast media, is it paid by patient or covered by healthcare system? Our answer is in Germany, it's covered by healthcare system, but we don't get more money for the examination. We get only the money for the sonoview material and color Doppler examination. Okay.
These are in Romania, we're lucky that in Romania it's covered by insurance. Then we have this package of daily hospitalization of contrast-enhanced ultrasound, and this is paid by insurance. The patient don't pay nothing. We can make this how many times we like to have for the diagnosis.
Okay, we have another question. Perhaps if we at the end we have some time, you can give the answer. We come to the next point now. We are just in time, and the next lecture is given by Roxana Shirley, focal liver lesions, casuistics.
Hello, everybody. After you heard a few things regarding the normal aspect of the liver, the examination technique, as well as the aspect in different diffuse liver disease, it is my privilege to present to you today focal liver lesions, but starting from clinical cases. So the first case that I will present you is of a male, young male, 35 years old, who presented for a dyspeptic syndrome, nothing specific, with normal biologic test. And this is what we saw in ultrasound. As you can see in the left liver lobe, there is a large anechoic lesions, approximately 4 centimeters in diameter, with very thin walls and also with posterior amplification. Based on this aspect, my main suspicion was of biliary cysts. What are these biliary cysts? There are congenital anomalies with the starting point, the biliary canaliculi. They are bordered by a single layer of epithelial cells. This is why the wall is so thin. They are filled with fluid. This is why they are anechoic. Their size can be variable, up to 10 centimeters. They can be unique or multiple, but the characteristic in ultrasound is that they have a very thin wall, and sometimes they have this geographical delimitation, which are very characteristic and allow a positive diagnosis without the need for other imaging methods. Another thing, thin septa, like here, can exist, but they are also thin like the wall. The second case is a 60-year-old male who was admitted for abdominal pain, predominantly in the right hypochondrium. The onset was approximately 5 days before presentation. On clinical exam, he was jaundiced. He had abdominal pain in the right hypochondrium, spontaneously and on palpation, and also he had mild hepatomegaly. Regarding the laboratory tests, increased liver function test with transaminases 1.5 times the upper limit of normal, also an increased total bilirubin, and also cholestasis. And this is what we saw in ultrasound. Again, an anechoic lesion, but not perfectly anechoic. You see here a few echoes. The wall was thin, and also we can observe dilated intrahepatic biliary ducts. Which are the differential diagnoses? Biliary cyst, considering the ultrasound aspect and the clinical data, the thin wall, the anechoic content, less likely a hydatid cyst, and this is also confirmed by the fact that the anti-echinococcus antibodies are negative. And also we have dilated intrahepatic biliary ducts secondary to the compressive cysts. And we perform a cholangio-IRM and it revealed the presence of several cysts, the largest one, the one that I showed you in ultrasound, which had a compressive effect on the main biliary duct. We perform an ultrasound-guided aspiration, and you can see here the needle inside the cyst, and fluid was extracted. The liquid was clear, transparent. The culture from the aspirate was negative, and also the parasitologic exam from Taenia echinococcus was negative, thus definitively confirming the diagnosis of hydatid cyst. Following aspiration, liver function test went back to normal in a few days. So the final diagnosis was a large compressive biliary cyst, which is indeed a rare complications of these lesions. The third case is of a male, also 35 years old, who presented for the ultrasound assessment of a dyspeptic syndrome. And this is what we found in ultrasound. Several lesions, at least 3, which are seen in this image, which are cystic images, anechoic, and which have a very thick, well-delineated wall. Based on this image, we suspected an hydatid cyst, and we performed the anti-echinococcus antibodies, which were positive. So our final diagnosis was of hydatid cyst. The hydatid cyst is a parasitic disease caused by Taenia echinococcus. It is frequently localized in the liver and the lung, but other locations are also possible. The diagnosis test is anti-echinococcus antibodies, which have a sensitivity of more than 95%. Among the ultrasound typical features, the thick walls and the presence of daughter cysts. What you must remember that the aspect of the hydatid cyst may vary according to the and Garvey and collaborators first introduced the classification of hydatid disease based on the ultrasound appearance. The type 1 is a pure cystic fluid collection, as you see here, with a thick wall that corresponds to a young hydatid cyst. Type 2, the fluid collections with a detached membrane. It's an aspect we wish to encounter after treatment of the hydatid cyst that means that the parasite has died. Type 3 is a fluid collection with multiple septa, with rosette-like aspect or honeycomb aspect. It's a cyst with daughter cyst in a solid matrix. It corresponds to a mature cyst. Type 4, it has a heterogeneous appearance. There are hypoechoic and hyperechoic areas, and this is the most difficult to differentiate from a tumor. A contrast imaging method is needed. And the type 5, in which the walls of the cyst are calcified, which correspond to an old cyst, a dead cyst. The fourth case is of a female who was admitted for the evaluation of a retrohepatic mass. You see it here. This is the right liver lobe, and this is the mass. Her only complaint was fatigue. It was a normal clinical evaluation, a normal lab test, and for the diagnosis of this tumor, we decided to perform a core biopsy. 24 hours after the core biopsy, the patient complained of pain in the right upper quadrant and fatigue, and a drop in the hemoglobin levels by 3 grams. And this is what we found in ultrasound. You see this one and the second lesions, inhomogeneous lesions with an anechoic content and also an echoic content. And based on the clinical data on the ultrasound aspect, we suspected a liver hematoma, which was later confirmed by other imaging methods. The fifth case is of a 56 years old male who had a personal history of diverticulitis 6 months before the presentation. For 3 weeks, he presented fatigue and fever, which was diagnosed as caused by pneumonia, and he underwent an antibiotics treatment for 14 days. But it showed no improvement in the clinical state and also weight loss. At presentation, he had leukocytosis, elevated function test, and also elevated inflammatory markers. And this is what we saw in ultrasound. In the right liver lobe, this large image with hyperechoic and also anechoic content. We decided to perform puncture and drainage because we suspected the presence of a liver abscess. And this is the catheter that we introduced. You see the catheter here. We introduced under ultrasound guidance in the anechoic area. And this is what we extracted. We extracted pus. The final diagnosis was liver abscess. Liver abscess is a collection of intrahepatic pus. The ultrasound aspect is of hypoechoic, inhomogeneous, poorly delineated image, as you see here, which also has an anechoic content. Sometimes we can observe posterior amplification, but the clinical context is very important with malaise, fever, leukocytosis, and the anamnesis can reveal the infective moment. The image that you saw in the patient, it was not so typical of liver abscess because he was already undergoing antibiotics treatment and the abscess was well delineated. The sixth case is a 39-year-old male who presented for dyspeptic syndrome with normal biological test, and we performed ultrasound. And in the liver, you can see several lesions, one here, and a little one here, and another one here. Or all of them are hyperechoic, well delineated. Their size is smaller than 3 centimeters. And based on the ultrasound aspect, we suspected a diagnosis of liver hemangioma, which were confirmed by contrast-enhanced ultrasound. Liver hemangiomas are the most common benign liver tumors that can occur in up to 20% of general population, being more frequent in women than in men. They are considered to be vascular malformations of congenital origin, which enlarge by ectasia rather than by hyperplasia or hypertrophy. There is a hormonal influence over tumor growth. The typical ultrasound aspect of hemangioma is, like you see here, of a hyperechoic, homogeneous, well-delineated lesion up to 3 centimeters in diameter, as you saw in our patient. But hemangioma can have an atypical aspect, like you see here, of a hypoechoic inhomogeneous lesions larger than 3 centimeters. And here you must perform a contrast-enhanced imaging method for the differential diagnosis with malignant tumors. The seventh case is of an asymptomatic 27-year-old woman with normal biology who undergoes a routine ultrasound examination. And what we can see here on the margin of the left liver lobe, we see this isoechoic lesion that protrudes from the contour of the liver, and which also has in the center this hypoechoic, let's say, scar. On Doppler examination, you can see here a spoke wheel pattern. So the vessels go inside the focal liver lesion and they go to the periphery in a spoke wheel pattern. Based on this ultrasound aspect, we suspected a focal nodular hyperplasia, which was later confirmed by contrast-enhanced ultrasound. Focal nodular hyperplasia are benign liver tumors, most often in an incidental finding. They are the second most frequent benign tumors, also more frequent in women, and they are considered to be an hyperplastic response to an abnormal congenital vascular anomaly. In standard ultrasound, their aspect is of an isoechoic mass, sometimes slightly hyperechoic, sometimes with a central scar, which is a very suggestive sign for the positive diagnosis. In Doppler ultrasound, the spoke wheel pattern that I showed you is also seen, and it's rather characteristic. In patients with steatosis, the focal nodular hyperplasia can be hypoechoic as compared to the hyperechoic liver tissue in steatosis. The 8th case is a 73-year-old female with poor general condition and weight loss, who also had a discomfort in the upper right quadrant, and she also had a sideropenic anemia. And this is what we found in ultrasound. We saw these lesions, these bullseye type lesions, one here and one here, which are very suggestive for liver metastases. We also performed contrast-enhanced ultrasound that confirmed the diagnosis of liver metastasis, and by colonoscopy, we diagnosed a colonic cancer. As you know, liver is a frequent location for the metastasis of different malignancies. Their diagnosis is very important because they can modify the treatment strategy of the primary tumor. In standard ultrasound, their typical aspect is, as you can see here, like a bullseye lesion. They can be also hyperechoic or hypoechoic, but you need a contrast-enhanced imaging technique in order to establish the diagnosis of metastasis. And finally, the 9th case is a 77-year-old man who was known with alcoholic liver cirrhosis. And at presentation, he had mild cytolysis, a total bilirubin of 2, with normal alpha fetoprotein, and he underwent screening ultrasound for hepatocellular carcinoma with the last ultrasound examination performed 6 months ago. And when you examine the liver, you can notice the presence of ascites, the irregular surface of the liver confirming the diagnosis of cirrhosis. And also you can see these 2 small lesions, one here and one here. They are small, less than 2 centimeters. And considering the history of the patient, there was a major ultrasound suspicion of hepatocellular carcinoma, which was confirmed by contrast-enhanced computer tomography. Hepatocellular carcinoma is the most frequent primary malignant liver tumor. It represents up to 85% of primary malignant liver tumors. Usually it occurs on liver cirrhosis in more than 90% of the cases, or in patients with severe fibrosis. So each new nodule in patients with liver cirrhosis should be considered as hepatocellular carcinoma until proven otherwise. Early diagnosis can be done by surveillance, by screening by ultrasound in patients with liver cirrhosis every 6 months, together with the measurement of alpha fetoprotein. So the take-home message of my presentation is that ultrasound is an excellent imaging modality for the detection of focal liver lesion, having the advantage that is inexpensive. It doesn't radiate the patient. It is repeatable, accessible, and it is also a real-time imaging modality. But it lacks specificity. So in most focal liver lesion, we cannot make a positive diagnosis by B-mode ultrasound alone, and we need contrast-enhanced imaging method that can be contrast-enhanced ultrasound, contrast-enhanced CT, or contrast-enhanced MRI. Thank you, and I'm waiting for your questions.
Thank you very much, Roxana. We come to discussing. Are there some questions?
There are several, as I saw here.
There was a question if it is more difficult to make interventions in a focal lesion in fatty liver, or what can you do if the lesion is not good visible in fatty liver?
I can answer to this one. One solution is to use fusion. Sometimes it's used fusion. You can have the image from CT or MRI, and then by combining both the image from CT or MRI with the ultrasound, we can touch or we can make the puncture of the lesion. This can happen maybe in 5% of our cases where we are not able to see very well the lesion to make this procedure function.
Okay. Another question was, how are you working when you find a focal liver lesion? Are you doing contrast media ultrasound in time, or are you doing it later and you write it in your report? What is your procedure?
If I will respond to this, matter a little the machine that you have. If you have the machine with contrast, usually we try to make immediately the examination by contrast-enhanced ultrasound. Sometimes it's in place where you don't have a machine that have the module for contrast, then you put in your report and you refer the case for contrast-enhanced ultrasound.
Yeah, I think that's also my opinion. It depends on the machine. It depends on time, what you have and whatever. Yes, you need, sometimes you need the coagulation parameters and others. Yes.
You must have you must have a nurse. Usually we use a nurse.
Yeah, yeah. You must have a nurse, time, and the right machine. Yes. Every time. And there's another question to Roxana. How common are Haida teeth cysts in Europe?
Well, that depends on the area of Europe. In the Mediterranean basin, they are more frequent. Romania was considered a few years ago as an endemic area, but from my clinical practice, I noticed that the frequency which I found hydatid cysts decreased. In Northern Europe, I think, as you said, that there's not such a frequent disease, the hydatid cyst.
Yeah. I have seen my hydatid cysts, and I made my images in Sudan and not in Europe. They are very seldom. In North Europe, they are very seldom. Okay, are there some other questions in the chat?
Sorry, they repeated the question regarding point shear wave elastography, and I think we have a little bit more time. The question is it if point shear wave elastography, if it is more reliable than FibroScan, why do you think it is not replacing it in the hepatitis C and B national patient evaluation?
There are some comparative study between the method, between transient elastography, point and 2D. Maybe from my point of view, maybe they are somewhere to the same level of accuracy. And like all the method, need to have some time before, because the oldest method is transient elastography or FibroScan. Then it's on the market for the last maybe 15 years. It had enough time to be put in guideline. But in this moment, there are some guideline, the EFSUMB, European Federation, or WFUMB, World Federation guideline, that give us the right to say that all DC method, point 2D and transient elastography, can be used for daily practice. That's from my point of view. Despite sometimes some national regulations are not updated, from the point of view of scientific papers that are behind the reality, we can use all these methods for evaluation of a patient.
Thank you very much. There's another question of our friend Yu Hong. Please, Yu Hong, could you open your microphone and give us your question?
My question is for Roxana. I would like to know how about the percentage of spoke field pattern on color Doppler ultrasound if you do a diagnosis for focal nodal hyperplasia?
I think that you can see it in almost 90% of the cases. I didn't make a study, but in most FNH that I see, we can also see this pattern. What do you think, Professor Spura?
In contrast, yes, in contrast.
In color Doppler. In color Doppler.
Roxana, before
we perform contrast. Now
yes,
we can perform it.
you know, usually we don't look too much. Maybe we take some image by Doppler to have for our presentation, but when you have a lesion, we go directly in contrast in ultrasound. I don't pay too much attention to this sign. Maybe in previous time, before contrast in ultrasound, we try to see the Doppler appearance, but now we go directly. Only we make some image for our presentation or something like this. Then from my point of view, I don't look too much. I don't believe too much. I know that it's there, but we use contrast because it's so nice, the diagnosis. And just last week was published a paper in our national journal that's in English of ultrasound and multicentric study. Roxana was the first author about the value of contrast in ultrasound in focal liver lesion, in focal nodal hyperplasia, and the results are very, very good for practice using contrast for FNH.
Based on my experience, it's around 45%. So not quite, not
Well,
beyond 50%. Yeah.
As per Professor Spora, I looked at it only in FNH that I recorded for CUS, the typical. So it was a little bit backwards. We did contrast enhanced ultrasound that made the diagnosis, and we later searched for the spoke wheel pattern. We are spoiled. We have CUS.
And you know, Roxana, about this topic, we can because Tudor was in duty of the literature. This is medical ultrasound. That is a free journal, and it's in English about ultrasound. And the paper was just published about the value of contrast in ultrasound for FNH. If somebody interested, the journal was published last week. It's medical ultrasound. It's called the journal in English.
I think, Johan, in the time before the contrast media ultrasound was available, our percentage of differentiation with color Doppler was better and higher. And now we forgot to use it because we have a better tool now. Thank you, Professor Yihong Chow. He is from Taipei in Taiwan. He's a famous professor in ultrasound, and you can see such a lot of books in his background. No one has so much. Yeah, that's really perfect. And now we come to the next point, and I have seen already that is Niels and David. They come from Germany, from our university, and they want to work with you in a question and answer session.
Yeah, thank you very much for the introduction. So the next part will be an interactive part, and you have 3 options to join our Mentimeter session. The first one is, I also gave it here to the chat. There's a link to the Mentimeter quiz. You can also join it here, or you can also join with your mobile phone, and we prepared a short introduction. So I will split my... So I think you should see it. So this will be the first page of our webinar, and you can also join on the website on Menti. So you can go with your smartphone, your tablet or laptop or so on. You can go on menti.com and then you can join us with the code you can see here. And the other option also beyond the link, you can also see in the chat, is the QR code, which is on every page from our short introduction. So how does it work? So this is also the page when you see it on your own phone, the Mentimeter, you can join us with the code and then also submit it. This is what you see on your screen on your phone. This is the first page also from our Mentimeter session. And the most important part of Mentimeter is you can also interact with us. So there are also some questions about it, or maybe where you're from. You can leave your answer here and also submit, and then we can all see your answers here. So all instructions, videos, and questions are also on your phone. And the results are on the shared screen. So I will share my screen here and you can also see the results after it. When you have some problems or so on your phone, there's also a chart where it tells you can go back to the slide where you came, or you can also refresh the Mentimeter part to go back to the last session also. Exactly, and this is also the QR code, or you can also join us with the link. Okay. Then I would say we can also start. So I would give up on David and also share the Mentimeter session.
Yeah, welcome to our small session. We like to give you a little bit time to join. If there are any problems, please share the problems in the chat with us so we can troubleshoot. We're going to start with the question. One is, where are you from? We are very highly interested. Where are you from in the world? Who is an early riser in North America or late into the night to watch the presentation? So please, Nils, du hast jetzt umgestellt, no?
Yeah, sorry, it must work.
Yeah. So please pin your location on the map. Japan is with us. Norway again.
I think it's not the best time for America.
Too early, or it's 8:30 in the morning. Maybe some early risers.
Okay, so I think we can go on and start with our first.
Should we wait 30 seconds, 15
Yeah,
seconds?
we can. Yeah, exactly.
30 seconds so more people can join us. Are there any problems to join us in this session? The text is in German. Oh, okay, that won't be the problem with the answers.
It can be changed to whatever, like to English. It can be changed to English.
Yeah.
So it's only that you can go on menti.com. So all important stuff is also in English here.
Oh. Okay, let's start. Africa is strong, Europe. Yeah. You can still join us with the code. It's no problem. Okay, let's start. Your first patient got an ERCP. 2 hours after the intervention, you repeat the ultrasound scan and you see the following image. Liver ultrasound. Picture is a little bit dark, but you can see it quite well.
We can help a little bit. It's inside of the liver. Look at the probe position here. Yeah.
The important thing is it's post-intervention.
Okay.
Now you have to choose 11 participants, 12, 15. Okay, get more points if you answer fast. What do you see in the picture? There are some answers to choose from. Yeah, most of the participants are right. It's the aerobilia. You can see inside the bile tracts the hyperechogenic air, the small bubbles. Okay, next patient. Your patient is a 50-year-old male with a BMI of 37, and you do an ultrasound exam of the liver. What can you see? We have to look fast. Sorry, I have to close the windows. Please don't answer in the chat. Yeah, we heard about the pathology of the fatty liver disease in the presentation, and for the people who don't participate, you can see the difference in the echogenic. The kidney, it's much darker, less echogenic than the liver. And that's the first sign for a fatty liver. if you do first time scan, that there is a big difference between these parent tumors. Yep, you examine a student, ultrasound shows no previous illnesses and no complaints, young student, maybe 22 years old, and you see the following thing in the loop.
Hemangioma.
Maybe.
Please, no spoilers.
The right answer is situs inversus and hemangioma.
Okay, so
We will have a look if it's right.
yeah. So 3, 2, 1. Let's see. I think there is a high chance of yeah, everyone is right. For the beginners, Professor Neumann, would you like to elaborate a little bit?
Yeah, you see a sharp, limited sharp bordered echo-rich lesion, and you have no symptoms, a young boy, asymptomatic. Some areas, it's a little bit inhomogeneous. Perhaps it's not a capillary, it's an cavernous hemangioma. And what you can see here in our last webinar, Professor Yu Hong spoke about mirror artifact, and that is very nice. You can see on the other side of the diaphragma, you can see the mirror artifact of a liver vein and the lesion in the liver. That's perfect. Thank you. Everyone was right.
Yeah. Your next patient is 35-year-old female, Caucasian ethnicity, and a BMI of 39. This is the ultrasound picture. And now the question. We're not looking for the pathology, we're looking for the artifact in the picture. It's a beginner question, but yeah.
Acoustic
No
shadowing.
spoilers, please.
Yes, there's acoustic shadowing and it's a gallstone.
Yep.
Acoustic shadowing. There's a gallstone. Cholecystitis.
Dear friend, next time please use the Mentimeter. And if I am the teacher and you have to go out of the classroom if you tell the other one what is the result before they can vote. Okay, next time, please you can vote in chat or use the Mentimeter. And learn it for the next time. We will repeat it next time with other cases.
Yeah, also last question, you see an ultrasound picture of the liver, and it's also a beginner question, but a very important question, I think. So just look at the picture, look at the vessels and the surroundings. And now, what vessel were shown, or vessels were shown in the picture? Easy question, but important one. Yeah, everyone is right. Everyone is familiar with the standard ultrasound. Very nice. Yeah, and we can see it again, what all was right. These three thick vessels in the area of the liver, the hepatic vein star.
Okay, so your day is also going on, and now you have a little bit older patient. So your patient is 94 years old. It's Mrs. G, and she has been coming to the rescue center for several weeks with progressive dyspnea. You are on duty and carry out an ultrasound of the abdomen and thorax for orientation. So, and this is your ultrasound loop you can also see by Mrs. G. So you have two lesions here, what you can also see. And maybe there's also a question about it. So the first question will also be about this one here. And there's also a question about it. And question number 6 is, what is your diagnosis for the claim of 1? Is this one a liver cyst? Is it a liver hemangioma we also saw? Or is it maybe a malignant liver tumor? So she's also 94 years old. What is your answer about it? Yeah, perfect. Everyone is right. You can see it also here. So you have an echo-free lesion in the liver here. It's very round, not in the hepatic parenchyma. Also hyperechogenic after the cyst here. And so this is only a hepatic cyst here. Perfect. So we're going on. We also saw there's a second one here, and this is not echo-free. You can also see, what is your diagnosis for the liver cavity claim number 2? I think you can also answer here. So 1 is for malignant liver tumor, 3, 5. 1 liver hemangioma, 2. So most of you are for a malignant liver tumor. 1 is also for a liver cyst, but which is bleeded in. Okay, so the case had a following ultrasound loop. And this is the next examination of your liver lesion, and you also made it source here. You can see on the right side, needs a little bit more time that the contrast enhancement can also include into the liver. And this here on this side is this lesion exactly. So you will also have a look at this. You can see the ultrasound, the bubbles go into the liver. This is our liver cyst, our first one, and this is the second one. So, and for that, we also have a question. After your source examination, what do you think is it? Is it also malignant liver tumor? Is it a liver hemangioma? Or maybe a liver cyst, which is bleeded in? That's interesting. That's the opposite from the last question. So 2 are also for malignant liver tumor, and the right one is a liver cyst, which is bleeded in. You can also see it here. So you have the mass in this cyst also, and this is old blood. And you can also see it here with a contrast enhancement. That is no contrast enhancement into this cyst. When you have a malignant tumor, you also have some gain here in the cyst, and you don't have anything here. So this is only blood. And I think it's a good loop also to see the differences and what for which cases you can also use the Zeus ultrasound. You can see it. And you don't have any perfusion here in the cyst. Perfect. Okay. So the next question is, what pathology is depicted in the following picture? So this is the picture. You're also here in the liver region. This is your ultrasound machine here, and you have to look at the liver. And you see here something different. What can this be? So you have also 3 options. Is it maybe a gunshot wound? Is it liver cysts? Or is it maybe an Echinococcus multilocularis lesion? Time's up. Okay, 8 are for the liver cyst and 4 for the lesions, and no one is for the gunshot wound. Oh, there's one picture missing. You're also right, it's the liver cyst. You can also see it here. You have also round artifacts here with a hyperechogenic reflection after the cyst. And these are multiple cysts in the liver. That's totally right. And you also have your last patient on the day, and you examine a 34-year-old male patient after a motorcycle accident. And you also have an ultrasound loop here. You're also in the liver here, and you see this picture. You also have the vessels here and also a source. You see this picture. It's a little bit different to the old lady. So he's not 94 years old, he's a young man, only after the motorcycle accident. So here's also the question, and also the last question. What pathology is depicted in this picture? What is it? Is it a contusion of the liver? Is it also a liver cyst? Or is this a malignant liver tumor nobody has seen before because he hadn't any ultrasound loop before because of his age. What do you think? Okay, 10 up for the contusion of the liver, and that's totally right. So also the red flag was the motorcycle accident. You can also see here the same thing as in the 94-year patient. You have a round lesion here into the liver and no contrast enhancement into this lesion. And here in the B mode, you can also see there is something into this cyst, and it's also a bleeding thing here into the liver after the accident. And I think here it's also a very good loop to show how you can different between malignancies or after trauma, and it's also very fast, and you can also combine it with a eFAST in the ambulance. Okay, perfect. So then one of the most important parts, how look the leadership.
Okay.
So we have a winner. On the first place, we have Earthman.
Who is Earthman? Please open your camera. From where you come. Who is the Earthman? Can't see it. No one? Please give us your chat if you are the Earthman. There's an information. I don't have any name. No. Okay. Next. Perhaps we will find him. And the second was?
The second was Puffy.
Yeah, that's what was me.
Again.
Okay, and the third?
The third is Nemo, like the fish.
Nemo. Who is Nemo? Please open your camera and your microphone. We want to see you. Okay, next time. We come to the end now. Thank you very much, Niels and David, for the nice casuistics and for your quiz. And we hope for more attendance in the question and answer part next time. You can try it before the Mentimeter. That's not, I learned it, then you can also learn it. And yeah, Earthman, Puffy and Nemo. Okay. And do we have some other comments, Johan? I think I have only to tell you that we make a break in the August now, and at the 2nd September, it's also a Thursday, we will have the next webinar, students webinar from WFUMB and EFSUMB, and it's about biliary diseases. The speakers, there are Professor Alina Popescu from Timișoara and from a hospital in Trier, Germany, that's a surgeon, an ultrasound performing surgeon, that is Matthias Wüssner, and they speak about biliary diseases, and we hope we will meet you again. Johan, you have the last word now.
We are happy that was quite 100 students, and I believe it's the start of interesting series of presentation, and probably to the biliary we'll have more and more. And please, dear students, inform your colleague about this interesting lecture that you can have for free. And these are something that we hope that you enjoy, being something that is not very, very difficult, and it's the interactive one. And we hope that in September to see you all for the next webinar from this